So this is our last talk, and even though I positioned this talk as outcomes and management in natural history of PA, many presenters today mentioned just how similar management of PA and MMA could be, and also there's quite a significant overlap with many other organic acidemias. And so this is how I'm going to sort of present this information to you today. I also want to mention is that the way the story is going to go is I'm going to take you behind the scenes, because you've heard so many things today, and in many ways our talks complement each other. But I don't want to repeat things that have already been said. So what I'm going to do is I'm going to sort of take you behind the scenes, what happens in in nurses' offices when you get a call or you have to deal with in-house sort of or home situation or hospitalizations. And hopefully that will help you process a little bit your personal experiences. And we'll see how it goes. First, I would like to start with acknowledgments. This is usually the last slide. I usually try to bring this forward so I have your full attention. None of this would be possible without your participation, and I wanted to thank our families, patients for your courage to participate in many different natural history studies, contribute to registries, and also now participate in clinical trials. So thank you very much. And I wanted to thank Dr. Venditti and many other wonderful colleagues at NIH and referring physicians who make this all possible. Dr. Venditti already mentioned that NIH is just right across the street. Well, it's not quite right across the street, but it's just like 5 minutes away from here. So if you have never participated in a natural history study at NIH and you would like to, and you figured out how to get here, it's just 5 minutes away from here, so it should be fairly easy. Now, the studies at NIH can be very involved. So those of you who came to NIH, probably most of you stayed there for 5 days. So it's pretty intense. It's probably one of the most comprehensive studies of your disease you will ever have in your life. We usually start on Mondays. We usually finish on Fridays. You get to see lots of doctors, get blood collection, let's skip that. Although those who had been to NIH know what it means, right? It's usually a lineup of many different tubes, and we collect lots of blood and urine and other samples. And we store all of those samples. Some of them are processed. We generate numbers. You heard today that we use it for the discovery of biomarkers, surrogate endpoints, which we then publish, and pharmaceutical companies use them to enable their clinical trials. So we already published a pretty large data set on PA, and I've seen some of the clinical trials. They published information on primary, secondary, and exploratory endpoints, and I see that those endpoints are already being incorporated. So, and that's all because of you, because you are able to participate in natural history studies. I just wanted to briefly mention that the MMA has been around since 2004, and more than 260 subjects with MMA-related syndromes have already participated. So it's more than 1,200 visits. So collectively, we're talking about a lot of expertise that had been accumulated at NIH. The PA protocol is a little bit younger, so we started in late 2017, early 2018. Unfortunately, got interrupted by COVID, but even though we were able to enroll more than 40 patients in the study, and we have quite a few publications that is being prepared, and at least 2 of them have been recently published. I'm not going to dwell on this too much, because you've already seen this slide in one way or the other many times today. But I just wanted to mention that in addition to protein and amino acids that are present in our foods, which is the source of propionate, there's another a significant source of propionate, and that comes from the gut. So we have live bacteria that live in the gut, and there's a large group of those bacteria. What they do is that they naturally produce propionic acid. And it's one of the ways that they defend their turf against other bacteria and as well as fungal organisms. Now, under normal circumstances, that propionic acid is actually really good because it keeps our gut very healthy. And we as humans are readily able to use that propionate and put it to work and produce lots of energy from it. It's actually just, it's amazing when we use labeled propionic acid in the clinic here at NIH, just how quickly we see, instant production of CO2, which is sort of the end product of that pathway in otherwise healthy volunteers. So that tells you that our human body is well prepared to deal with this propionic acid. Unfortunately, in patients with PA and MMA and other related syndromes, it's a source of big problem. So unfortunately, it accumulates in the body and causes lots of problems. We also discovered that other biomarkers in blood, FGF21, GDF15, can be quite useful to both stratify patients in terms of their risk for severe outcomes, as well as potentially they can serve as surrogate endpoints as candidate biomarkers. Now, the importance of this pathway is difficult to overemphasize, because we know when it breaks down, it can cause a lot of problems. And this is just a small assembly of problems that that we all deal with, both as families, patients, and physicians. And I just wanted to mention a couple of them: optic nerve atrophy, cardiomyopathy that is quite prevalent in propionic acidemia, but some of that can also see in patients with MMA, although not as frequently by any means. We see patients with fatty liver and enlarged liver, weak bones, osteopenia, or suppression of the bone marrow, gut dysmotility, like a lot of patients deal with that problem, right? Is lack of appetite, or frequent nausea, vomiting, or constipation alternating with diarrhea, or chronic constipation or chronic diarrhea. So a lot of those complications stem from just the underlying disease itself. And pancreatitis. So we've seen all sorts of scenarios, acute episodes of pancreatitis, the inflammation of pancreas. Chronic pancreatitis, they sometimes leads to the loss of beta cells. That's where insulin is being produced, and some patients even need to go on insulin injections to help them with glucose metabolism. So that's common. One of the more surprising findings that we made through our natural history study is the finding of chronic kidney disease and propionic acid. And it's not like we were the first one to notice. We were the first one to document just how prevalent it is. And in adults, we see up to maybe 50% of adults will have some evidence of chronic kidney disease. The good thing is doesn't progress as fast as in patients with MMA. So you tend to see it in the end of the second decade of life, third decade of life. But something needs to be done, right, to monitor for those complications, and certain things can be adjusted early on before this disease gets to its more severe stages. Some of the most disappointing outcomes of this disease stems from the effect of MMA and PA on the brain. So we see both intellectual disability as well as autism in patients with propionic acidemia. Interestingly enough, the autism part is not as prevalent in the MMA. And so when we work with our colleagues from NIMH at the National Institute of Mental Health, they're quite surprised by that. And it's been an area of research. In fact, we have a very mature draft at this point, soon to be submitted, where we try to dig a little deeper, try to understand what is the difference and why we see this in one disease, not the other, as prevalent. Try to understand the mechanisms of autism. And that's sort of a byproduct of natural history studies, where you get to discover something that is maybe not quite related to PA and MMA, but benefits other patients with other conditions. And of course, some of the most feared complications, that's metabolic instability, and many families have had experience many episodes of metabolic decompensation. So the way I'm going to arrange the rest of the talk is that we're going to talk about scenarios. Okay, so the first one I wanted to bring, and I apologize if it brings the flood of memories, but I hope that by sort of going through these slides, it will help you understand what's been happening on the possibly happening on the medical side of it. So hope it may help you process things a little bit. So for many families, the journey starts with that call from a doctor's office about abnormal newborn screen, or these days, or a finding on routine evaluation that requires additional attention. And more often than not, at this stage or this age where we have advanced, newborn screening programs, every baby in the United States is offered, and the vast majority of babies have newborn screen done on their blood spots. So what usually happens is that blood spot gets sent to a special lab, which that is able to extract chemicals from the blood spots, put them on extremely sophisticated machines. Those machines are hooked up to very complicated computer programs. They analyze just en masse, lots of data, and looking for those chemicals that we know are associated with propionic acidemia, methylmalonic acidemia. And if some of these chemicals, trigger or go above a certain threshold, then that generates a report. That report gets back to the doctor's office, and they look at it and then contact the family and say, like, well, I just wanted to let you know that we found this chemical. Don't worry about this, but we're going to try to figure out what the source of it is. So for PA and MMA, the chemicals that doctors or nurses or people who are working in the labs will be looking for is an elevation of C3. C3 simply refers to the number of carbons in that chemical. So in case of propionic acid, it's 3 carbons, which is why we refer to it as C3. So usually, that leads to a visit to a doctor, and then they will order follow-up studies. Sometimes it's called confirmatory studies, sometimes it's called second-tier tests, and that's where you will see urine samples are obtained, blood samples are obtained, and those results come back relatively quickly. And so again, those are things that we would like to sort of separate patients who are truly effective from patients who are not effective. And believe it or not, C3 is actually discovered in the clinic, elevated C3 discovered in the clinic very, very frequently, especially in hospitals where they have neonatal ICUs. It's a very common chemical there. So it's called false positive. Those kids more often than not do not have a real disease. But in order to separate them into those who are affected from those who are not affected, you have to do additional studies. And then you probably have to do some additional weighting. If you remember probably from your experience, is that you almost get to that point, you feel like, okay, are we there yet? Are we done doing this confirmatory testing? And the answer is no, because we're waiting for one more test, and that is the molecular DNA confirmatory testing, where they will look at individual genes, and we try to look for that misspelling in the DNA. And the part of the DNA that stores the instruction on how to make these enzymes. And if you may encounter a situation that doctor calls you maybe a week, well, not a week really these days, but 2 weeks later, 4 weeks later, 6 weeks later, and says like, okay, we need to have a longer conversation. Let's talk about, your DNA findings. So if you go through these steps, usually you will be able to have a firm sort of affirmative or confirmation saying that yes, you have that condition, or no, you don't have that condition. So there are problems with the newborn screen. It's because, like any screening test, it's only a screening test. It's not designed to confirm things. So it can have difficulties detecting patients with mild forms of PA or mild forms of MA. And there's just many reasons for that it's the case, but usually that's kind of how it happens. So if probably many of you heard about families who were not detected on the newborn screen, and because some of those chemicals just happened to be just under the threshold where the program would have sort of initiated those follow-up studies. There are many different types of methylmalonic acidemia. So there are methylmalonic acidemias, and so they have, they may require quite a complicated approach to confirming these diseases. Maternal B12 deficiency. A mother may have insufficient amount of B12 in the body. When the baby is born, it will have secondary B12 deficiency. It can be picked up on the newborn screen. It has nothing to do with genetics. Just, it can be easily addressed, but it can also present with a positive newborn screen using this method. And so there are many other diseases that enter in the differential diagnosis. This is something that doctors and nurses have to go through when we evaluate patients for elevated C3 or if there's a clinical suspicion for it. So there are lots of different steps. And then I hope that helps us to explain why does it take such a long time to get sometimes the definitive answer. And I wanted to thank you for being very patient with your care teams as they try to navigate through this pretty complicated algorithm. So I'm going to pause here and see if there are any questions. And feel free to interrupt me at any point, by the way, if you have any questions.
So
Yes.
Primary carbon marker.
So you would see C3, but also there's a problem with that approach is that homocysteine typically you will not find that as part of the standard panel. You will see methionine, but so the vast majority of algorithms are set up to find elevated chemicals because it's just easier to find something that is higher than normal. But methionine soon after birth will tend to be low, right, in patients with cobalamin C. And there are lots of different clinical scenarios in otherwise absolutely healthy babies where chemicals can be low. It could be the extraction method, it could be not enough blood in the blood spot, it could be all sorts of reasons. So for that reason, using low methionine has not been as helpful to detect. So you have to use a combination of several things and ratios to increase your sensitivity. It usually comes at the expense of specificity, but that's a different conversation. All right, I'm going to go to the next step here, a metabolic crisis. So sometimes you get a phone call while you are already at a hospital dealing with a metabolic crisis. And sometimes that actually helps to solve the problem because in many cases, a metabolic crisis will look just like, let's say, episode of sepsis in a newborn. Doctors will spend a lot of time trying to figure out, okay, what might be going on here? And then there was a phone call to the family and the treating doctors, and they said like, oh, okay, well, now we have a lead and we know how to follow up on it. And I'm not going to go into details about what exactly happens biochemically here, but there are quite a few things that happens in infants or patients' body and body fluids that can provide a clue as to what might be going on and whether this is biochemical disorder. The problem with everything that you see here on the list is that it can be present in patients who do not have a metabolic disease. And the patients who do not have a metabolic disease vastly outnumber patients with rare metabolic disorders. And somebody today during a presentation mentioned that homocystinuria, for example, there could be like a paragraph or two as part of medical school curriculum, as opposed to neonatal sepsis that, you will be sort of like bread and butter of medical school curriculum. The doctors may not be thinking about rare metabolic diseases, not because they're not smart, not because they don't care, but because it's just that their medical practice can shape their understanding and perception of clinical situations in a hospital. Now, the management at the hospital can be pretty complicated. And of course, there are some general outlines and there are some general guidelines how we manage patients in order to stabilize them. I'm not going to go into any of those details. But one of the probably more feared complication that we know that is linked to outcomes is elevated ammonia. That's why you will hear ammonia all the time when patients are hospitalized. And one of the benefits of doing a natural history study is the opportunity to interact not only with doctors here in the United States and families here in the United States, but a lot of doctors and patients internationally. Especially now with the use of telehealth, we actually get to know quite a few patients from overseas. One of the more recent discoveries that we connected with a clinic in Mexico, in Mexico City, and it's a different world. They may have fewer resources than available here in the United States, but you also learn about different ways of managing the diseases that we kind of manage them in a certain way, and that all of a sudden opens up quite a few venues for us to maybe critically examine what we do, maybe get some new ideas, especially when those practices are implemented across the entire clinic. So you kind of have a way to compare. Okay, well, if they do it this way, why don't we do it the same way? For example, one of the recent experiences I had interacting with international clinics is the use of sodium benzoate as a chronic supplement to manage hyperammonemia, which is kind of interesting, intriguing, positive outcomes. So I'm kind of looking forward to following up with that clinic. Now, there are a couple of controversial topics. Well, I shouldn't call them controversials. These are topics that require a discussion. Many families struggle or wrestle with the question of whether to get a G-tube. If yes, then when? And there's no right answer right or wrong answer to that question. But G-tube is one of those things that in many situations makes life very easy. Especially if it's a patient who comes to the hospital very frequently or gets dehydrated frequently and requires rehydration. This is something that your doctors will approach families affected by PA and MMA at some point. And some families will say like, oh, I wish I could have, I would have done this a long time ago and I just didn't think about this or didn't have a chance to discuss this with the doctors. And some families I've seen where a G-tube was placed, but the patient did quite well with oral feeds after all, so it was taken down later. So all sorts of scenarios, but G-tube is one of the bigger topics. You've heard a lot about the use of antibiotics or antimicrobials, Flagyl or oral vancomycin. There's rifaximin recently that we had an opportunity to follow up on it. So why would doctors use that? We already talked about sort of one of the sources that we have propionic acid is gut, and because that's the normal part of normal gut flora. The unfortunate part about any of these antimicrobials is that it suppresses not only what we call propiogenic or propionogenic gut flora, but also lots of other good bacteria. So it sets up patients for constipation, for diarrhea. And so I feel like I have a lot of mixed feelings about this because families I interacted with have lots of mixed experiences. So it may not work for everyone. So it's a little bit of error in trial in every single situation. So there are long-term consequences related to the use of Flagyl or vancomycin. It's resistance to antibiotics. With Flagyl, there's a high risk of peripheral neuropathy, increased incidence of pancreatitis. So, it's you have to weigh pros and cons in every single situation. Probiotics, I get that question a lot. So, is it okay to use probiotics? And again, we don't know the answer to that question. So, because we study microbiome both in mice and patients with MMA and PA, we kind of got to know that topic a little better. But interestingly enough, some probiotics that are available on the market, if you actually look up some of those bacteria, they happen to be propionogenic bacteria that naturally make propionic acid. So, I'm not sure if it's a good idea to introduce additional propionogenic bacteria into the gut. So, but the thing is, usually probiotics are not standardized. There are some probiotics that's exactly the same strain. There's a lot of standardization goes into it. Sometimes it's just a mix, and you can't exactly know what goes into it. So it's an open-ended question at this point. Biotin supplementation. A lot of patients get started on biotin. A lot of patients don't need it, but continue on biotin. So we talked about a little bit about how to transition to an adult clinic. So it's one of those legacy drugs, people just keep using until there's very little harm associated with the use of biotin. But one of those things that the vast majority of patients we've seen probably don't need it. Maybe I'll just shorten the list here and maybe jump to Zofran. So I was pretty dogmatic initially when I started working with PA and MA patients about never using Zofran, because it can increase the long QT, especially in PA population. But with time, I learned to be a little more probably flexible in my thinking. I certainly see patients who have Zofran for nausea, chronic nausea, but it definitely requires a follow-up with cardiology. If cardiology clears you and says it's okay to use it once in a while, under control of your doctors and nurses' advice, it's okay. But again, it has to be cleared by cardiology and your doctors. Sooner or later, every single patient goes home, right, after that initial hospitalization, if everything goes well. And then you have to deal with this different set of issues. So I'll just mention a couple of them. We hear a lot about ketones, and we hear about the use of keto sticks, trying to figure out if it's a good time I need to go to the hospital or I can stay at home. And I think if you ask different doctors about the use of keto sticks, you will hear different responses. And that's because how unpredictable keto sticks can be in detecting ketones or even helping us triage patients. So if in doubt, talk to your team. Diet modification or, sick day diets. Again, one of the things that I really like what Dr. Corson mentioned today is that if you use a sick day diet, which sometimes actually saves you a trip or two to the hospital, for sure. I'm pretty convinced that if you use it wisely, it can actually prevent a hospitalization, a certain percent of situations. But if you use it very frequently, it can actually lead to a situation of protein deficiency. Because if, some patients say like, oh, I use it like once a week. And that's probably too much. But if it's a different story, like if it happens 3-4 times a year, so that's a different situation. In any of those circumstances, it needs to be discussed with your metabolic team. Dr. Chapman mentioned the use of paracetamol and ibuprofen. Certainly we see that, and that's probably a good use of those medications to reduce the use of calories during that time and reduce the metabolic stress. Dietary management, I mentioned G-tube. We talked a little bit about low protein diet. One of the questions that we still don't know the answer to is what is the role of medical foods? And what I mean by that is not just pro-free or dual-cal, so many families present here are using it, but what about other special amino acid mixes which don't have the propionogenic amino acids? I'll just name a couple of them without any particular reason. Propamex 1, Propamex 2, Anamix, XTMVI, and so on. So it doesn't really, most of them use exactly the same approach to designing their formulas. The exact ratios and concentrations could be slightly different. I have to say that I thought that it's not possible. Before I started to work on this protocol, I didn't think it was possible to manage patients without medical foods. But I've encountered a lot of patients, in fact, some of them are sitting here, who managed to achieve really good outcomes without medical foods. So if you ask me, at this point, I'm not sure what the right answer is. In any case, though, it has to be a low-protein diet because that's the source of propionic acid. So the exact ratio of the medical foods to complete protein is still not clear to me. Probably 70-30% is a good place to start for severe patients. For milder patients, I see quite a few of them come without any medical foods. But again, they have a milder form of propionic acidemia, methylmalonic acidemia. So, at this point, it's not clear. I think we continue doing research. Overnight feedings, so a G-tube, a use of G-tube allows you to do overnight feedings. And I think that's probably a situation where a patient has a lot of gut dysmotility, constipation or food intolerance, frequent nausea. So this is when, doctors will advise, well, let's try to use some of that food, slow down the amount of food is given in a given time, maybe even do this overnight as an overnight feeding. There are some specific complications associated with the overnight feedings. We do need fasting period. Just the way our body is set up, we need to have a prolonged period of time that allows us to clear fats and carbs from our blood. Otherwise, when you continue to give fats and carbs, around the clock, unfortunately, it's just not good for our body. Our liver begins to suffer. So, Is it a temporary measure for some patients? Yes. Is it something that, can be maybe designed in such a way that can still give or create that window of no food given overnight? I think it's something very important to discuss with your doctors. And we talked about the sick day diets. So one of the things I do want to mention is that, this snapshot I took from the previous guidelines for MMA and PA that was published in the journal called JFIMD by the European group. And they had a really nice table there where they summarized protein requirements. And I'll just want to highlight some of the numbers you may see. If you look at the number here, it's 1.7 and 77 grams per kilogram per day for very young infants. And you can see how the total amount of protein goes down to 0.8, 0.9 grams per kilogram per day. By the time patients get to being young adults, for example. So it's a moving target, but even now, I still see some patients getting much more protein than they probably need to normally grow. So it has changed dramatically, I think, over the last 10 years. I think I see fewer patients who get more protein than they actually need for normal physiological growth. But still see once in a while that they're sort of like, they get 130%, 150% more than they need, above 100%. So it feels like we still have some work to do. And the best group of people who can do that work is our families and patients and parents who can sort of raise those questions with your metabolic dietitians and revisit some of those numbers. And again, the emergency feeding sick day diet, there are different ways of approaching this particular issue. Sometimes we see that the complete protein is removed for, let's say, up to a day. Sometimes we see that the ratio of medical foods and complete protein doesn't change, but just the overall amount of total protein is decreased. There are different approaches to managing, but the key thing is not to let that fasting period go for too long, because the body will get to a point where it will start breaking down its own protein, and that's not a healthy stage. All right, the monitoring at home. There are lots of different things that we can talk about this. I just probably want to focus on a couple of things. There will be some routine labs that your doctors will be getting. And as you look at them, there are different approaches to how we do it, but probably plasma amino acids is going to be part of it. It helps us with dietary guidance and dietary management. CBC, that's when we look for evidence of anemia or neutropenia, right? Low levels of white blood cells. Thyroid hormones, vitamin D, triglycerides, and I would recommend that if you can add proBNP, and especially in patients with propionic acidemia, that's probably going to be a good use of your money and laboratory resources. And that's proBNP is used to screen for evidence of dilated cardiomyopathy. Okay, so just again, there's something you can add to the list of labs. There are some additional topics that are under discussion. Maybe I just wanted to highlight one of them. Those families who came to see us at NIH or who had done telehealth visits, you heard us say about the use of cystatin C as a way to screen for chronic kidney disease. Chronic kidney disease is something that is part of both MMA and PA clinical presentations, and unfortunately, creatinine-based formulas that are used to screen for kidney disease don't work as well for in patients with MMA and PA. There are reasons we can spend like an hour talking about the reasons for that, but we're not going to do that today. But cystatin C is another chemical that is now available in the vast majority of hospitals in the United States, and it's probably a better way to screen for chronic kidney disease in patients with these conditions. And there's another debate. It's a sort of a little bit controversial topic about the use of echocardiogram, EKG, and Holter monitoring to screen for cardiac problems in both MMA and PA. And the question is when to start it is is controversial. Some doctors will insist on doing it every year, pretty much starting with the first year of life. Some doctors will wait until the second decade of life. So it's something that your cardiologists and your doctors can decide depending on your particular clinical situation. So there's really no one-size-fits-all answer to that question. I want to spend a little more time, and depending on how much time do I have. How much time is it right now, by the way? 5:05? Okay, I have 10 more minutes? 10 more minutes, okay. So poor growth, that's, short stature. So that's one of the more common complications that I see in patients with propionic acidemia and methylmalonic acidemia. And I would like to maybe just make a quick tour through different things you might consider. It's a very common outcome. And unfortunately, there's really no straightforward answer to, well, what do you do when you encounter stunted growth in patients with MMA and PA? It's a common complication, probably way more than 50% of our patients experience this. And the way I think that we could approach this particular topic is that look at this problem from many different angles. Approach number one. Try to understand the severity of the propionic acidemia. Let's say if we deal with the patient Amish type propionic acidemia, which tends to be mild. Some of these patients can be so mild that they can be missed on the newborn screen. It's a known fact. In those patients, we should expect them to grow better. On the other hand, what we have shown in our natural history study is that patients who have severe form of propionic acidemia, meaning very little enzyme activity remaining or present in their liver, those patients will have more stunted growth. So trying to, for example, I've seen it sometimes an attempt to increase the protein amount in the diet as a way to stimulate growth in some patients, especially after liver transplant. And we feel that that's probably not the most optimal approach to dealing with short stature. If there's severe disease, the possibility for that body to grow to its full potential will probably be limited. So it kind of needs to be taken into account. The second thing that we need to take into account is parental height. So, we know from just natural observations that taller patients tend to have taller children and shorter parents have shorter children. Now, there will be significant variability across, no family, every family is going to be very different. But there's a general tendency, right? We kind of, there are no surprises there. If you combine the severity of the propionic acidemia with parental heights together, that will explain about 50 to 60% of the patient's height. In other words, variability in those two parameters will explain about up to 60% of variability in the patient's height. So that means that this is probably one of the most important drivers of the final height outcomes in patients with PA and MMA, and sort of that probably needs to be taken into account before, in terms of expectations for the final height. Now, diet. Both excessive amount of protein can cause problems with stunted growth, and not enough protein can cause the same problem. So that's another approach, another angle the families can take. And there's some additional considerations such as plasma amino acids and the amount of formula that is present. So it's definitely one of those things that requires a lot of analysis by metabolic dietitian groups and dietitian colleagues. And finally, the role of transplantation. At this point, I do not see a signal in our natural history data set suggesting that transplantation will increase patients or will improve patients' growth. But I intuitively feels like if patient doesn't go to the hospital very frequently, if the patient's diet and the quality of the diet improved, it may contribute to improved growth outcomes. I think more often than not, we see patients transplanted at the time after their growth spurt is complete, and therefore we may not be able to actually see the effect of transplant in those patients. But if it's done early on in the first year of life, 2 years of age, for example, there's much more potential for transplantation to change that trajectory. we talked a little bit about chronic kidney disease. I'm going to skip that. So I'm going to, oh, of course it's a good topic, but there's one thing that I think is going to prime us for one of the conversations, and it's this one. So when we started this protocol, so what, 5 years ago or so, when you look at the percent of patients at that time who were adults in the PA cohort, a third of our PA patients were adults. Now, when we look at the cohort today, it's actually more than 50%. To some extent, it reflects a lot of hard work on behalf of you, the families, the patients, and the improved understanding of the physiology and approaches and treatment to this condition. So, in a sense, this is something to celebrate. We see a very similar trend in the MMA cohort, although the percent of patients in the current cohort who are 15 years of age and older is smaller. But one of the things that I think a lot of people mentioned is just the difficulty of transitioning from the pediatric world into the adult world, because they are very different. It's surprising how different pediatric hospital can be from an adult hospital, but it's true and it's definitely there. And so there are lots of issues surrounding this. And I feel like this is, if there's one thing that we can make a big difference here, is for all of us in registries and patient advocacy groups and parents and patients and NIH, is where we can make a big difference, is to create or help improve that transition by maybe putting guidelines or some additional publications out there that will guide the process. But again, it looks like as I'm looking at some of these cohorts that continue to age, which is excellent news for all of us. I also feel that we are, dealing with new problems that we have to solve somehow. One way to approach this is to train in genetics physicians who are trained in internal medicine. So traditionally, genetics has been a pediatric subspecialty. That's not the case anymore. We definitely see internists who choose to do additional training in genetics, or combined, trainees who have come with pediatrics and internal medicine together. Actually, currently, I'm a program director for residency training programs, and we have 2 doctors in our program who are trained both in pediatrics. Actually, no, 3, who are trained both in pediatrics and internal medicine, and are doing additional training in genetics. So this is one of the ways that NIH is adding to the solution of this problem. So I'm going to pause here and see if there are any questions. Yes.
Can you hear me?
Yes, I can hear you very well.
This hasn't come up, and so I'm just wondering, it only came up when, Gabrielle's 22, presented at birth, had severe acidosis. She smells a very distinct smell when she's getting sick, and I've never asked why. And sometimes I can smell it before she has any other signs, and I just wonder, why? I'm sure it's a chemical something, but would love an answer.
Well, I wish we could, we have something that we sort of have to keep under wraps for now. But yes, a surprise, yeah. So some of you, including some people here sitting in this room, participated in our study designed to study biomarkers in breath. So we were collecting breath samples in addition to other things that we described, but this was a separate study that we worked together with the company that is specializing in it. And we got our results back. We completed the analysis. I think we may be able to answer your question in part, not completely, but in part. And I think there's a very specific answer that may explain the distinct. It's a thing. It's a thing for sure. It's a thing. Yes, absolutely.
Biotin, again, Gabrielle's been followed by Dr. Corson and now by Dr. Sukmi. Never has she been offered biotin or even discussed. So what does it do? And
So there's a theoretical consideration that it can actually help improve outcomes in some patients, improve the enzyme activity. In fact, it's been described many, many years ago. There are specific, what we call genotypes, a combination of mutations in PCC that can possibly be responsive. In practice, though, if you look at the guidelines, everywhere you will see pretty much the same statement, is that biotin probably has no place in the treatment of propionic acidemia. I think the reasoning that doctors and nurses apply when they recommend this is that, so they're kind of, it's a two-dimensional problem. One is the side effect profile and the benefit. You always want to maximize the benefit with the minimal amount of side effects. But it's okay to have fewer potential benefits if the safety profile is good. In other words, it's not going to hurt. Why not try it? The problem is we try it, but we never stop it. And some patients go on for, staying on this medication for like decades, even though they never needed to be on it in the first place. So.
If they can test whether they're biotin responsive?
There is a way to test it, yeah. It's just in practice, it's rarely done. But like I said, and some doctors here who with a lot of expertise in, crystallography and molecular biology can probably correct me, but there is a theoretical consideration that biotin can help in some. Again, in practice, when you actually work with patients, I've never seen it. I've never seen the biotin responsiveness ever. So I'm not sure. But among ourselves, the doctors and people who work in this field, we talk about this a lot. Yeah?
You mentioned the cystatin C for the
Yes.
renal. Is there a reason why more hospitals don't use cystatin C for the renal disease?
To screen for it? Yeah. I've never heard of cystatin C until I started doing what I'm doing right now. Some of it is just simply reflects my pediatric background. We just don't screen for chronic kidney disease typically in the pediatric population. It's much better understood and known in the adult world, and that's yet another reason why we need to transition to our patients to the adult world, and get our adult colleagues ready to handle this type of patients. Maybe 5 years ago it would have been probably fair to say that not every hospital had access to standardized testing of cystatin C. That's probably not the case anymore. For most hospitals, can't speak for every hospital, but most hospitals. So I think should be part. I think that's why, again, this is why we have this conversation, and you will be advocating for your family.
Why is it more accurate? Why is it more accurate?
How much time do we have? Yeah. Okay. A short story. Okay. Or a short explanation. So creatinine is something that naturally occurs in our body. The vast majority of that creatinine comes from the muscle. Okay, so creatinine is freely filtered, and in its level, in a sense, reflects how well the kidneys are working. So the kidneys are working very well. It will maintain very low amount of creatinine. So doctors many years ago had done lots of studies on like thousands of people, and came up with formula that linked the level of creatinine to the kidney function. What we didn't really think carefully at that point is, what about patients whose muscle mass is decreased, or patients who are not eating normal protein diet, where those levels of creatinine will be artificially lowered. So when you plug those lower numbers into the formula, it gives you a really good renal function. And it sort of underestimates what actually is happening. Cystatin C does not depend on the muscle mass. It's produced in a very different way. It's filtered in a different way. Well, it's actually not filtered, but it's cleared in sort of similar way by the kidney. So that's why, because it doesn't depend on that, doesn't depend on the diet, doesn't depend on the muscle. In this patient population, it's probably better. So how exactly is it going to play out? Is it going to be a combination of creatine and cystatin C or cystatin C alone? It's an open-ended question, but Cystatin C, I think, needs to be a part of it.
Do kidney doctors and nephrologists believe that as well?
Oh yeah, absolutely. In fact, they will probably tell us, to use it. In fact, this is where I learned. Right, that's our nephrology colleagues at NIH. That's where I learned those things. Yeah. Any other questions? Yes.
So, you mentioned ammonia
Mm-hmm.
in your slides.
Mm-hmm.
So, the baseline ammonia for at least for our child has never been
Yeah.
established. She is a baseline in her ammonia is a little bit off, quite a bit off. And when there are episodes where she is decompensating and we are in the hospital, they are very reluctant to release the window when we say that she's at baseline.
Mm-hmm. Mm-hmm.
And how do we get to that? And ammonia is only tested when we are, in that kind of thing.
Wow, that's a difficult question, and I think there's just so many things, right, that go into goes into that decision. Ammonia is a number. It requires interpretation, and we know that for patients with PA, their baseline ammonia levels tend to be higher. Now, if somebody has ammonia greater than 100 micromole per liter, I would feel uncomfortable releasing that patient home. I would probably relook at the diet, the amount of protein the patient gets, and we'll probably even consider the use of sodium benzoate under some circumstances. It's not going to work on every patient. Some people have tried and use carboglue. As you heard today, carboglue is not approved for chronic hyperammonemia. It's approved for acute hyperammonemic episodes in the United States. So it's a difficult question, and I'm not sure there's a straightforward answer to that question. But I've heard this particular problem in more than one, situation.
You want to make a comment on medical food effects on ammonia?
Oh, yeah. There's another element. The medical food, Dr. Venditti is asking to make a comment about the use of medical foods. So if you look at the composition of medical foods, you will see that isoleucine valine will be depleted or removed completely. Again, depends on specific formulation. But there will be a significant addition of leucine, because leucine doesn't produce or doesn't become propionic acid, if you just look at the pathway there. And if you give a lot of leucine or sufficient amount of leucine to a healthy volunteer, these studies have been done quite a long time ago, it can cause elevated ammonia in otherwise healthy volunteers. So what I think we're dealing with here is just a combination of many different things that come together. So that's why I mentioned that I would like to take a look at the diet. Is that too much of medical foods? Is that too much of total protein the patient is getting? Is there a need for additional help in the form of, in the treatment of constipation, for example, because that's also can cause hyperammonemia. So there's just so many things coming together to work to cause elevated ammonia.
Then a follow-up question. So, talking to a practitioner in terms of asking them to consider gene
Mm.
It's a difficult topic.
Yes.
Because once everything is stable,
Mm-hmm.
you don't want to
Yes.
change. Any suggestion how to?
Well, reach out to us. We're happy to talk to your team and just sort of go over this. This is what we do all the time. We have those consults and we talk about those things. Yes, go ahead.
So, kind of piggybacking on that
Uh-huh.
statement about the ammonia levels, and I think the last question, so I'm not sure if they touched on this or not. But is there like a known idea of that threshold of the hyperammonia to say, all right, at this point now we're getting brain damage, or this point, or is there certain parts of the brain that ammonia is going to affect more than other parts of the brain, or is it just going to be hit or miss wherever? And kind of going back to your first slide there, or towards the beginning of your presentation, when it's first presented, and when you're waiting for the doctors to go through all those tests and go through that checklist and kind of narrow in on that, you have higher ammonia.
Yeah, so it's this is a little bit of sort of art mixed together with some evidence, and so you will see here, the threshold for a lot of doctors will be 100 micromole per liter for ammonia, and that will prompt them to do something about this, and then depending on how high it goes, then you will see different ways of managing it. So these recommendation comes from the first update to the proposed guidelines for the proposed recommendations for the treatment of PA and MMA, and this came out in 2021.
So the 500, anything greater than 500, or is that what you're counting?
500, yeah, that's 500 is an emergency that requires a lot of things that have to happen,
I
and.
mean, is that during that period of time, is there already guaranteed brain damage at that point?
I'm not sure I would use the word guaranteed, but is it a significant risk factor? Yes, it is. I mean, common knowledge. Yeah. But it's a range, and I think there's quite a bit of variability how patients respond to hyperammonemia. Some patients will have symptoms with very small elevations of ammonia. Some patients, oh gosh, I remember 10 years ago I had a case. A patient was, a girl, we brought her to the emergency room, and for some unrelated reason, and there was something that came up on her studies, and she was just talking to me like just the usual day. We measured her ammonia, she was like 250 or something like this, something that like a true emergency. And it's like, how you're just sort of talking to me and normal stuff. And you see, there's a significant variability in how patients respond to hyperammonemia. So I'm not sure one size fits all is sort of like is a good way to think about this. But like I said, these are probably reasonable sort of guidelines. These numbers that I'm showing here. Again, it's in the public domain. Everybody has access to it, and you can review those.
What about like parts of the brain that is affected, like versus like speech or different parts? Is there any?
I think we have more answers to that question in the recycled disorders community, where a whole lot more work has been done. And specifically showing how executive functioning can be affected by elevated ammonia, with less information available for other things like speech or cognitive development in terms of math or mobility. There's more work that needs to be done in PA and MMA. I'm not sure we know the answers to those questions.
Thank you.
Oh, all right.
I want to say thank you. We could probably
Thank you.
sit here all night.
Yes. Okay. Thank you so much.